Well, since here we are at the feet, we've almost gone from head to toe in this series. I'll bet many of us take our feet for granted, unless we have foot problems, because painful feet can make it tough to have a happy day. Our feet do so much for us, yet we slam them against the pavement while jogging, shove them into uncomfortable shoes, or take jobs that make us stand on them for 8 or more hours a day. And in return, our feet can get smelly, blistered, sore, and just worn out. There are entire stores devoted to footwear. You don't see that with many other body parts. And even a special branch of foot medicine called podiatry. But now, put your feet up for a half an hour, because in this lesson, we'll take a good look at the musculoskeletal anatomy of our feet. As I like to do, let's set the stage by talking about a 12-year-old boy who was running across a plowed field on his grandparents' farm. The ground was uneven, and this poor kid stepped in a hole and over-inverted his left foot. He limped back to the house, and his grandpa noticed that the lateral side of the boy's ankle was swollen and tender. Out of an abundance of caution, and because we grandparents don't like sending our grandkids home damaged, they went to the local clinic. X-rays were negative, but the nurse practitioner noted the tenderness seemed to be anterior and distal to the lateral malleolus, especially when the foot was inverted. What's the diagnosis, and what should be done for this kid? We looked at the skeleton of the feet in our last lesson, since we really needed that to understand the insertions of muscles in the leg. As we know, in the limbs, the origin is always proximal and the insertion always distal. So, of the many muscles in the leg, all but popliteus cross the ankle joint and attach somewhere in the foot. We learned that in each foot there are 7 tarsals, 5 metatarsals, and 14 phalanges. And the tarsals in particular are linked together like pieces in a jigsaw puzzle. Just imagine how many ligaments are necessary to hold that complex together and support the weight of our entire body, plus anything that we're carrying. Even in my graduate level gross anatomy, I don't begin to cover all those ligaments, but they generally come in dorsal varieties on the top of the foot and plantar versions on the sole of the foot. As a bonus, they're usually named sensibly enough that you can pretty easily figure out which bones they connect. However, we do cover the ligaments at the ankle, also called the talocrural joint between the talus and the tibia and fibula of the crural region or leg. So let's do that now. Medially at the hinge joint of the ankle is a set of ligaments collectively referred to as the deltoid ligament. This is because they fan out like a triangle, like the Greek letter delta, from the medial malleolus of the tibia, and they attach to various tarsals. This deltoid ligament can be broken down into 4 bands, and they provide good examples of ligaments with names that make sense. Notice that in each of these, tibio is the first name of the ligament, if you will, and the tarsal it connects to is its last name. There's an anterior tibio-talar ligament, a posterior tibio-talar ligament, a tibio-navicular ligament, and a tibio-calcaneal ligament. The anterior tibio-talar is deep to the tibio-navicular, so it can be difficult to see in images depending on the view. This deltoid group is very strong and resists over-eversion of the foot. On the lateral aspect of the ankle joint, there's a series of 3 bands with really no collective name, though they're sometimes jointly referred to as the lateral collateral ligament. Jointly, there's another pun. There's an anterior talofibular ligament, a posterior talofibular ligament, and between them is a calcaneofibular ligament. Notice that in a pattern similar to the naming of the bands of the deltoid ligament, these lateral ligaments all have a tarsal to which they attach as their first name, but have the fibula as their last name. So, to avoid confusing the names, I emphasize to students that on the medial side, the leg bone term comes first, but on the lateral side, the leg bone term comes last. Anyway, these lateral ligaments resist over-inversion of the foot and are not nearly as strong as the ligaments of the medial ankle. The ankle joint has a thin anterior and posterior capsule, so its main reinforcements are on the sides, which is typical of a hinge joint, as we know. Within the foot itself, there are also intertarsal joints, which are gliding joints between the various tarsals, as well as tarsometatarsal joints that link the distal row of tarsals to the 5 metatarsals. And these are gliding joints that allow planes of movement like during inversion and eversion of the foot. Moving distally, there are metatarsophalangeal joints, sometimes called MTP joints, between the heads of the 5 metatarsals and their proximal phalanges. These are condyloid joints in which the heads of the metatarsals are rounded and abut concave surfaces on the proximal phalanges. Now remember, condyloid or ellipsoidal joints allow more movement than simple hinge joints. And as a result, at the metatarsophalangeal joints, we get not only flexion and extension, but abduction, adduction, and even a little circumduction. Within each toe are interphalangeal joints, called IPJs, with collateral ligaments on either side. There's one interphalangeal joint in the big toe between its proximal and distal phalanx, and 2 interphalangeal joints in each of the smaller toes, which remember contain 3 phalanges each. Have you ever heard of a bunion? It occurs when the big toe's metatarsophalangeal joint gradually becomes misaligned, a tendency that is inherited. But did you know that the same misalignment can also happen at the MTP of the little toe, where it's called a bunionette? That sounds almost cute, but I'll bet it's just as painful. Bunions can make it difficult to find shoes that fit comfortably, but can also affect the range of motion at the affected joints. Speaking of joint movement, you may know that some people, particularly those without the use of their upper limbs, learn to use their feet to aid with daily activities or hobbies. In these cases, they don't alter their bony anatomy, but rather train their muscles and stretch their ligaments for these new tasks. Okay, before moving on, let's cover a few more tarsal specifics. The talus is said to have a head, neck, and a cube-shaped body. While the body articulates with the tibia and fibula, the head faces anteriorly, or better said, distally. Some references indicate it as forming more or less a ball and socket joint with the concave surface of the boat-shaped navicular bone. Besides its role in ankle movements, the talus functions to transmit the standing weight of the body from the tibia to the other bones in the foot. The calcaneus is the largest foot bone and forms the heel, as we know. Medially on the calcaneus is a small shelf called the sustentaculum tali because it widens the calcaneus just inferior to its articulation with the talus. I caution students that sustentaculum tali is not on the talus, but rather on the calcaneus to help sustain the talus above it. The calcaneal tuberosity is a prominent attachment site on the inferior and posterior surface of the calcaneus. But the Achilles or calcaneal tendon attaches to the superior and posterior aspect of the calcaneus. Remember, that's the insertion of the gastrocnemius, soleus, and plantaris of the posterior leg. If the calcaneal tendon completely ruptures, I've heard it makes a popping sound and almost rolls up like a window shade. The gastroc and soleus wad up near the posterior knee, leaving the person nearly unable to walk and needing surgery. While we're talking about pathologies, you probably know that stress fractures can occur in the feet. These happen most often in the second and third metatarsals. They get their name because these are typically caused by repeated stresses that weaken a bone to the point that it cracks. Why the second and third metatarsals? Those are usually the longest and thinnest, so the most vulnerable of the metatarsal group. During my first summer of graduate school, I developed a stress fracture in my right foot. I had just started working as an archaeologist, and stress fractures often result from a sudden change in activity. In my case, slamming my foot against the back of a shovel without the proper steel shank boots. It hurt so bad that I took time off from shoveling and did soil screening for a couple of weeks. By the time I got to the doctor, he said the fracture was already healing, so all I needed to do was use crutches for a few more weeks and let nature finish the job. That's the advantage of pain forcing you to rest, I suppose. Okay, on to muscles. Most people are surprised to learn there are a dozen intrinsic muscles within each foot, more than are in each hand. 10 of those muscles are in the plantar foot, and they are considered in 4 layers. So let's start with the easier set of muscles, the 2 on the dorsum of the foot, which are the extensor hallucis brevis and extensor digitorum brevis. If you remember, there aren't any intrinsic muscles on the dorsum of the hand, but we do have a pair on the top of the foot, and each has a longus buddy in the anterior leg that we learned about in the previous lesson. Both extensor hallucis brevis and extensor digitorum brevis take their origin off the anterior and lateral surfaces of the calcaneus, as well as the inferior extensor retinaculum on the dorsum of the foot. Now, due to this common origin, some references don't even separate out the 2 muscles and simply collectively call them the extensor digitorum brevis. But the difference is clear. Extensor hallucis brevis inserts on the base of the big toe's proximal phalanx, while extensor digitorum brevis inserts on the second, third, and fourth toes, actually on the lateral sides of their extensor digitorum longus tendons, which have small extensor hoods like those in the dorsal hand. So extensor hallucis brevis extends the big toe at its metatarsophalangeal joint, while extensor digitorum brevis extends the other toes, except for the little toe, at both their metatarsophalangeal and interphalangeal joints. These brevis muscle bellies are deep to the tendons of extensor hallucis longus and extensor digitorum longus that run distally along the dorsum of the foot. In lab, we often have to move the longus tendons aside to find the 2 small brevis muscles. What about their innervations? Remember that the deep fibular nerve supplies muscles of the anterior leg? Well, that nerve continues distally to supply the extensor hallucis brevis and extensor digitorum brevis. And if you remember this fun tidbit from our lumbosacral plexus lesson, that deep fibular nerve then becomes cutaneous as the flip-flop nerve between the first and second toes. Moving to the plantar surface, I should first mention that the skin on the sole of the foot is thick and protective, like the skin on the palm or hand. In addition, this plantar skin is firmly attached to deeper structures, unlike on the dorsum of the foot, which has loose skin like the back of the hand. If this plantar skin wasn't anchored to the deeper structures, the skin on the sole of the foot would slide around like a loose sock. Deep to this thick skin is a triangle of connective tissue called the plantar aponeurosis, more commonly known as the plantar fascia. Its apex attaches to the calcaneal tuberosity, and its wide end attaches to the heads of the metatarsals. In the relatively common condition called plantar fasciitis, the attachment of the aponeurosis to the calcaneus becomes inflamed, causing significant heel pain, especially during the first few steps in the morning. Runners and dancers can develop small tears in the plantar aponeurosis, but just being on your feet all day can take its toll. Obesity can overstress the fascia as well. Not wearing shoes with a supportive footbed is what caused my case of plantar fasciitis. This is because this plantar aponeurosis not only protects deeper nerves, vessels, and muscles, but also helps maintain the arches in the foot. There are a pair of longitudinal arches that pass between the heel and the toes. The medial arch is higher at the instep, as we know from the pads in our shoes, while the lateral longitudinal arch is lower. There's also a counterpart transverse arch running medially to laterally across the plantar foot. It's also higher at the instep and lower laterally. The many ligaments on the sole of the foot help maintain those arches, as do several plantar muscles, as we'll see. Now, there are some tricks to learning the many muscles in the plantar foot. One helpful thing, as I mentioned, is to consider them in 4 layers. There are 3 muscles in the first layer, 2 muscles and 2 tendons in the second layer, 3 muscles in the third layer, and again, 2 muscles and 2 tendons in the fourth layer. In other words, the first and third layers, the odd-numbered layers, each have 3 muscles in them, and 3 is also an odd number. The second and fourth layers, the even-numbered layers, have an even number of muscles in them, 2 muscles, and an equal number of 2 tendons. As for the innervations of the plantar muscles, if you remember, the tibial nerve, one of the 2 terminal branches of the sciatic nerve, supplies the muscles of the posterior leg. Then, at the medial ankle, really at the instep of the foot, the tibial nerve divides into a medial plantar nerve and a lateral plantar nerve. As we'll see, one, the other, or both of these supplies each of the muscles on the sole of the foot. And I have a few tricks there too, since many of my students come into graduate level gross anatomy without any knowledge of the muscles of the foot or their innervations. Those aren't usually taught in a typical undergraduate anatomy and physiology course. But let's get started. In the first layer, the 3 muscles from medial to lateral are the abductor hallucis, flexor digitorum brevis, and abductor digiti minimi for the little toe. There is no abductor digiti maximi. The counterpart for the little toe is hallux, the big toe. Now, most people cannot independently abduct their big toe, nor can most abduct their little toe on its own, though some people can, and I'm actually one of those freakish people. But when we think of abduction, we should picture fanning the foot out, like stretching to spread our toes apart. Abductor hallucis takes origin from the calcaneal tuberosity and plantar aponeurosis and inserts on the medial side of the proximal phalanx of the big toe. Not only does it abduct the great toe, abductor hallucis also slightly flexes the big toe at its metatarsophalangeal joint and helps to maintain the medial side of the longitudinal arch of the foot. Abductor digiti minimi also takes origin from the calcaneal tuberosity and plantar aponeurosis, and it inserts on the lateral side of the proximal phalanx of the little toe. In addition to abduction, abductor digiti minimi helps flex the little toe and maintains that lateral side of the longitudinal arch. The third muscle, flexor digitorum brevis, also originates off the calcaneal tuberosity and from the plantar aponeurosis directly superficial to it. In lab, it can be difficult to remove the plantar aponeurosis from the surface of flexor digitorum brevis without damaging the muscle. The insertion is on the 2 sides of each middle phalanx of the 2nd through 5th toes. Now, similar to what we saw in the hand, these brevis tendons split like a fork to allow the tendons of flexor digitorum longus, which are deep to the belly of flexor digitorum brevis, to pass through that fork and insert on the distal phalanges of the smaller toes. So when we curl our toes, the flexor digitorum brevis muscle is flexing the proximal interphalangeal joints, while the flexor digitorum longus is flexing the distal interphalangeal joints, as well as the proximal IPJs since it crosses both. Both muscles also help flex the metatarsophalangeal joints, but all this applies only to the 2nd through 5th toes, We'll talk more about the big toe in a bit. Regarding the innervations in this first layer of the plantar foot, it's no surprise that the medial plantar nerve supplies abductor hallucis on the big toe side, while the lateral plantar nerve supplies abductor digiti minimi on the little toe side. But what about flexor digitorum brevis? As I tell my students, flexor digitorum brevis is in the middle between the two abductors, so let the M in middle remind you that flexor digitorum brevis is supplied by the medial plantar nerve. That's not why, of course, but it does help remember the innervation. One more thing before leaving this first layer. The two abductors are really placed on the edges of the sole of the foot. They each insert on the outside aspect of their respective toes. So as we look at images of deeper dissections of the plantar foot, keep in mind that those two muscles really never have to be removed to see deeper layers. They form the fleshy mass on either edge of the foot, felt especially more towards the heel end of your foot. On to the second layer. Remember, even-numbered layers contain two muscles and two tendons. So in this second layer, going deeper into the plantar foot, let's first look at the two tendons. They're already familiar from our study of the posterior leg. One is the tendon of flexor hallucis longus, and the other consists of the group of tendons from the flexor digitorum longus. While the tendon of flexor hallucis longus is just passing through this layer, the tendons of flexor digitorum longus serve as attachments for both muscles in this second layer. Like we saw in the palm of the hand, a set of 4 lumbrical muscles weaves between and takes origin off the tendons of flexor digitorum longus. The lumbricals insert on the dorsal sides of the proximal phalanges of the 4 smaller toes, really into their tiny little extensor hoods from the dorsal side. By this pathway, as the lumbricals did in the hand, the muscles cross the plantar side of the metatarsophalangeal joints of the 4 smaller toes, so flex the MTPs, but then pass to the dorsum, where they weakly act to extend the interphalangeal joints on the toes. As in the hand, these lumbricals also have dual innervation. The one to the second toe is supplied by the medial plantar nerve, while the others are supplied by the lateral plantar nerve. As I often tell my students, our tetrapod ancestry causes limb similarities that can help us, but can be just different enough to confuse us as well. Now, the other muscle in the second layer of the plantar foot is quadratus plantae, a quadrangular-shaped muscle of the sole of the foot. It's really a two-headed muscle that takes part of its origin off the medial side of the calcaneus and partly off the inferolateral calcaneus. Both heads converge and insert on the lateral edge of the tendons of flexor digitorum longus. Quadratus plantae functions to adjust the pull of the flexor digitorum longus tendons to help them flex the toes. Quadratus plantae is lateral to its tendon of insertion, and that helps us remember it's innervated by the lateral plantar nerve. The third layer of muscles, like the first, contains 3 muscles, and 2 of those 3 mirror the pattern seen in the first layer. In that first layer, we met an abductor of the big toe and an abductor of the little toe, but in this third layer, there's a flexor of the big toe and a flexor of the little toe. Flexor hallucis brevis is a 2-bellied muscle that originates off the cuboid and lateral cuneiform. Its medial and lateral heads insert respectively on the medial and lateral sides of the base of the proximal phalanx of the big toe. In each of these muscle bellies, a sesamoid bone typically grows at the head of the first metatarsal. Remember, sesamoid bones are those that are seated within a tendon. So when we're standing, because of the arches present in the foot, we're really balancing our weight on the calcaneus distally and 2 sesamoid bones of the great toe medially, as well as the heads of the other 4 metatarsals passing laterally. No surprise, this flexor of the big toe is supplied by the medial plantar nerve. Laterally in this third layer, flexor digiti minimi, to which some sources add the adjective brevis, originates off the base of the 5th metatarsal and from the fibularis longus tendon that crosses the plantar foot. Flexor digiti minimi inserts on the lateral side of the base of the little toe's proximal phalanx. As its name implies, it flexes the little toe and does so at the metatarsophalangeal joint. No surprise here either. Flexor digiti minimi is supplied by the lateral plantar nerve. Now, between the 2 flexors in this third layer is an interesting 2-headed muscle named adductor hallucis. It has an oblique head that originates from the bases of the 2nd through 4th metatarsals and the tendon of fibularis longus, but its transverse head comes off the metatarsophalangeal ligaments of some of the smaller toes. Together, both heads insert on the lateral side of the base of the proximal phalanx of the big toe. The net result is a 2-headed muscle that roughly has the shape of the number 7, at least when looking at the plantar surface of the right foot. In terms of innervation, I teach my students to think about what the number 7 looks like upside down. It looks like an L. And wouldn't you know it, the adductor hallucis is supplied by the lateral plantar nerve. As the name implies, the adductor hallucis draws the metatarsals together, which helps maintain the transverse arch of the foot and helps support our feet while standing so the bones don't splay out. In the 4th and final layer, there are 2 muscles, really 2 groups of muscles, and 2 tendons. The tendons are from the fibularis longus and tibialis posterior muscles. Remember that fibularis longus is a muscle of the lateral compartment of the leg that sends its tendon completely across the sole of the foot from lateral to medial. As we just saw, the fibularis longus tendon is part of the origin for 2 muscles of the 3rd layer, but also helps support the arches of the foot by its insertion on the medial cuneiform bone and base of the 1st metatarsal. The tendon of tibialis posterior fans out on the medial plantar surface and links together several of the tarsals, including the navicular, cuboid, all 3 cuneiforms, the sustentaculum tali on the calcaneus, and even several of the metatarsals. The muscles of the 4th layer are familiar from our study of the palmar hand. These are the plantar and dorsal interossei. There are usually 3 plantar interossei, and they originate from the 3rd through 5th metatarsals and insert on the medial sides of the proximal phalanges. There are typically 4 dorsal interossei, and they originate between adjacent metatarsals and insert on the proximal phalanges. As we saw in the hand, the mnemonic devices pad and dab also apply here in the foot. Plantar interossei adduct the metatarsals and dorsal interossei abduct the metatarsals. I should add that in the foot, the axis of adduction and abduction is the 2nd toe, not the middle toe. And these aren't actions most people can perform willingly, but refer to the adduction that helps keep the toes pulled together when we're on our feet. Alternatively, abduction fans the toes out, like if stretching your foot, or like the repeated actions of their paws when a cat is kneading, or as some say, making biscuits. Both the plantar and dorsal interossei also aid flexion of the metatarsophalangeal joints, and both are supplied by the lateral plantar nerve. Though the dorsal interossei can be best seen from the dorsum of the foot, deep to extensor hallucis brevis and extensor digitorum brevis, they're still considered the deepest layer of the plantar foot, so as not to break innervation rules. To wrap up, let's return to our last clinical problem. And of all the awful musculoskeletal disorders we've talked about in this series, this one is a pretty simple and common injury that many of us have probably sustained. Remember the kid who was running and over-inverted his left foot? What does it mean to say that X-rays were negative? Yes, that means there were no fractures. But a fracture of the fibula, which is a relatively thin bone, can happen from an over-inversion injury. In fact, it's common enough that the eponym Pott's fracture is used for a distal fibular fracture, which separates the lateral malleolus from the shaft. The clinician in this case noticed tenderness just distal and anterior to the lateral malleolus. So this isn't a problem with the strong deltoid ligament of the medial ankle. We're much less liable to over-eversion. This injury has affected one of the three bands at the lateral ankle. If you suspected the anterior talofibular ligament, you're correct. This kid hopefully didn't fully tear the ligament, but is this injury a strain or a sprain? Sprain is damage to a ligament, while strain is a muscle pull. And as for what should be done, once again, our go-to is RICE therapy. The boy should rest the ankle, ice it, compress it with an elastic bandage, and keep the foot elevated. But though this is a common injury, did you know that the #1 risk factor for spraining an ankle is previously spraining that ankle? The ligaments get stretched out, so become more vulnerable in the future. So physical therapy can help protect the boy from future sprains. But while at his grandparents', he can put his feet up. Hopefully he and his grandpa have some good movies to watch together for the rest of his visit. As for what we will watch together, how about a cadaver lesson on lower limb? That's what we'll do next to close this series.